Here it is evening. So good morning, good afternoon, good evening. And I want to present from on behalf of our society, Thalassemia Sickle Cell Society, which is located in Hyderabad, on thalassemia, how to prevent. It is a preventable disorder. So I want to present in that. Should I share my screen or?
Yeah, I guess you should share your screen.
Okay, thalassemia and sickle cell anemia carriers among antenatal women. This is the first study ever study done in Telangana. So as you all know, thalassemia is a preventable disorder of red blood cells caused by defective synthesis of hemoglobin, protein that carries oxygen to all parts of the body, and results in reduced rate of synthesis of one of the globin chains that make up the hemoglobin. There are three, if you can see here, there are two alpha chains and two beta chains, and center part is the iron. So this is the structure of a hemoglobin. And normally when we see under the microscope, the normal cells are like this. It is a biconcave disc. And when there is a thalassemia, there is improper synthesis of RBCs, so it is different shape and sizes of the uh, red blood cells. And there are three types of thalassemia: alpha thalassemia, beta thalassemia, and delta thalassemia. So if you see the epidemiology, it's more than 4 lakh newborns are born every year worldwide, which affects 4 lakh newborns. And India considers to be the world capital of thalassemia. So the prevention is very much required, and which is easily preventable disorder. 10 to 15,000 babies are born every year, and carrier frequency throughout the world, it is around 3 to 4%, and in India, in some parts, it can be 10 to 12%. In several ethnic groups, it is 4 to 17%. It is predicted that every next 20 years, about 9 lakh patients with the thalassemia will be born in the world, with 95% of them will be in Asia, especially in India and Middle East. Why there is a reasons for the increasing burden? So if you see this family which came to our society, this family is a common scenario characterized by lack of awareness, wherein the father is a sickle cell anemia patient and mother is a thal carrier, and both children are sickle beta thalassemia. The family came for the consultation of one child, and during investigation, a father also found to be a sickle cell anemia patient himself. And he was complaining of recurrent joint pains but never advised for HPLC, and mother found to be thal carrier, and second child when investigated again found to be a sickle beta thalassemia. Another reason is improper counseling, because there is an inadequate genetic counseling resulted in the birth of 3 affected children in one family, not advised for prenatal diagnosis during subsequent conceptions, misled by the misconception that only 1 out of every 4 children would be affected, where there is every pregnancy there is 25% risk of bearing an affected child if both the partners are carriers. So there is an improper counseling. And there is again another burden for reason is religious belief. Parents driven by the religious belief decline prenatal diagnosis and termination despite there is a fetal genetic condition. So these are the few reasons. And again, another reason is late diagnosis. The first child is 13-year-old when she was diagnosed, and subsequently all other 3 children were also born. So there is late diagnosis is there. By the time she was diagnosed, the other 2 children were already born. So irony is that the mother is also a case of sickle beta thalassemia. which she was not aware of, and father is a sickle carrier. So this exemplifies how important the early diagnosis and antenatal screening is required. If this woman had been screened before, we could have saved the family from the agony of having 4 affected children in one family. So ultimate solution for overcoming burden is screening and prevention. That is the most important part and where the gynecologist comes into the picture. So why prevention? The lack of awareness leads to late diagnosis and increased mortality rate among the affected children. And patients required lifelong blood transfusion and expensive drugs to remove iron. And it is again a socio-economic financial burden on the affected families or the society or the healthcare system. And cost of ideal treatment for thalassemia child is 1.25 lakhs to 2 lakhs per annum, which is beyond the reach of many people. And only cure is bone marrow transplantation, which is very, very expensive. And again, HLA match donor is required. And this warrants the need for carrier screening and genetic counseling to prevent the incidence of this disorder. So the screening of the program, carrier screening program, premarital screening before marriage, population screening, and antenatal screening. And what is the pros and cons of the screening program? And for the premarital screening, suitable avoiding marriages between the carriers and the transmission of the defective gene. And premarital and preconception counseling can be offered. And what will be the problem in this type of screening? There will be an anxiety among the carriers, and in females, there limits the chance of marriages. And for the populations, suitable small populations are required and proposed and implement suitable preventive measures. And the cost-effective testing protocols have to be used, which, however, have high negative predictive value. And antenatal screening is the best suited program because everyone wants a healthy child. It is more cost effective. Implementing screening program is easy with the government support, and it limited chorionic villus sampling and amniocentesis sampling centers are required. And we have done one study. We initiated the screening of antenatal women less than 20 weeks of pregnancy in 2 places, Modern Government Maternity Hospital, Petlabruj in Hyderabad, and also PHCs of Mahbubnagar district, and in Bangalore in collaboration with Sankalp India Foundation. In case of pregnant women found to be carriers for those disorders, husbands were also screened. And in case of pregnant women where both the couples were found to be carriers, counseling was given and the prenatal diagnosis was advised to prevent the birth of the affected children. So we initiated this project in March 2021 in Petlabruj and in October 2021 in PHCs. And total subjects antenatal were recruited in Petlabruj 4,797 and in PHCs 3,013 and in Bangalore 11,954. Inclusion criteria was antenatal women less than 20 weeks of pregnancy and given their written consent. And exclusion criteria is more than 20 weeks of pregnancy and not willing to participate or not willing to give the written consent. So first we do the awareness and consent taken and the demographic data collected and 2 ml of samples were collected. And antenatal women less than 20 weeks and complete blood picture done. MCV is reduced, hemoglobin is reduced, MCH is low, HPLC was done. If HbA2 is more than 3.5 gram percent, the pregnant woman is thal carrier, or HbS is less than 50%, is a sickle cell carrier. Then husband was also screened, and if husband found to be carrier, then prenatal diagnosis was done. First, the couple genotyping was done, and then under ultrasound guidance, chorionic villus sampling was taken and it was subjected to the DNA analysis. If fetus was unaffected, then continue the pregnancy. If husband was normal, continue the pregnancy. If fetus is affected, then follow the protocol. So in Petlabruj, what we have done, 4,797 screening was done and 155 antenatal women found to be a carrier, to 3.2%. And husbands were screens were 146 and 5 of the husbands found to be carrier, and it was subject and fetus, positive fetus was not identified and fetal screening was refused in 2 patients. And 3 patients also found to be a sickle cell anemia, one with sickle beta, another one with E beta thalassemia, which was registered with our society and given the treatment. In Mahabubnagar, we found out of 3,013, 87 women found to be a carrier. It was 2.9% was the carrier rate. And the husband screen was 86. And the total husband screen were found to be carriers were 2. And they went for prenatal diagnosis was only 1. And in Bangalore, out of 11,954 patients, we found 540 were found to be a carrier, 4.5%, and 500 husbands found to be a carrier. And out of 540, and 72 were sent husbands were carrier. And the positive fetus identified was 10, and positive fetus still continued the pregnancy was 1. So the conclusion is this is the first study reporting the carrier frequency of hemoglobinopathies among antenatal women from Telangana population. And our findings were consistent with the carrier frequency ranged from 2 to 4% in different populations of India. And we found Sunni, Lambadi, Madiga, and Mudiraj found to be high carrier risk communities. And the high frequency of carriers warrants the need for antenatal screening at large for these disorders, as it is a preventable disorder during their early trimester in order to reduce the incidence of affected children. And this paper was also published in Indian Journal of Obstetrics and Gynecology Research. And this is our society where we have our hospital and where we take care of our thalassemia children. And 3,770 children are registered with our society. Thank you.
Okay, so I don't have a very good internet here. You'll forgive me for stopping the camera. You saw how I look, but then I will share the presentation for improved quality. Can you see the presentation?
Yes.
I hope you can. Okay. So yes, hello, and I'm very pleased to be here. It's an opportunity to discuss one of have regarding gynecology, which is hysteroscopy, and also how it can be used in one of the most frequent pathology related to gynecology, which is uterine fibroids. I come from Iași in Romania, in the northeast part of Romania. It's a very nice place to visit if you ever have the opportunity. I will wait for you at our university that you see below, or in our symbol, which is the Palace of Culture. A few things about myself. I'm a professor in obstetrics and gynecology in the University of Medicine and Pharmacy of Iași, Romania. I am a previous member of the European Society for Gynecological Endoscopy, advisor reproductive surgery, special interest group in ASHRE, and committees related to gynecology and to minimal invasive surgery. And I was interested in hysteroscopy for a very long time. I've done even my PhD in this topic. So if you're talking about the uterine fibroids, are related, first of all, to the present place of the ambulatory operative hysteroscopy. Then we will talk about the place of myomectomy in the hysteroscopy methods. Then we will discuss the two main techniques of hysteroscopy. hysteroscopy when you're doing myomectomy, safety and preparation measures, and finally, some new developments that might seem strange, but as you know, in medicine, sometimes you have to think outside the box, and maybe that will be something to follow. So, more and more the hysteroscopy, which was developed in the 1890s, I think, but technically speaking, it only come to the practice around the 80s. So hysteroscopy and operative hysteroscopy is also improvements of the equipment to be done in ambulatory settings, which is, of course, patient goes home the same day. It is very good for the doctors because it doesn't mean long post-operative follow-up. It's good for the hospital because it's less costly, and it's good for the company because you can improve your equipment every time you have the opportunity and the finance. But as you can see in this statistics from the Belgium Center of Gang, myomectomy remains one of the procedures which are done less frequently in ambulatory, although it is 60% of the cases. Nevertheless, the board of College and Obstetrics Gynecology, which is the governing training board for our specialty in Europe, mentioned that ambulatory operative hysteroscopy not to all our young doctors. Now, when you're talking about myomectomy, you might know the FIO classification because the fibroids can be very widely placed inside the uterus, and those who are accessible to hysteroscopy related in majority part inside the cavity or in majority part inside the uterus through the cavity. All the other types of fibroids are not accessible to hysteroscopy and therefore will not be the topic of my presentation. One thing which is particular in fibroids is that they have this pseudocapsule. So they are differentiated and have a precise border from the surrounding tissue, which in this case it should be the myometrium. This is something that, but also in hysteroscopy, more and more. The advantage for this pseudocapsule is that it allows the fibroid to move in between the myometrial fiber, and if you respect that to the myometrial tissue. What happens is that during contractions, this will be kind of pushed inside the cavity as a foreign body, if you like. This mechanism is very important in hysteroscopy. It was first described by Betoki, and it's called the office preparation for partial intramural uterine myoma, which is actually the use of different intrauterine pressures, which stimulates, of course, contraction, and therefore the myoma, which initially was maybe 75% inside the uterine wall, will become 50% inside the cavity or even more. Therefore, more accessible to hysteroscopy. And sometimes, and this is something you have to explain to the big myoma, or if it's very deep like type 2, but very big inside the uterine wall, you will need to use this mechanism and to call the patient after one cycle to complete the operation. So this is regarding myomectomy. Now, of course, we want to do one-step surgery. That will be ideal, but sometimes it's not possible. We want to do a surgery which is as simple as possible. And for this, there are some prognostic elements that should be taken into account. And there is this score, if you like, called the STEP W, which was proposed by Lasmar and adopted by most of the people doing myomectomy through hysteroscopy. And as you can see, this score takes into account the size of the fibroid, the topography inside the uterus, the extension of the base, which is actually maybe the type of the fibroid related, also the penetration inside the uterine wall, again, the type of the fibroid got into pure classification. And also it is important if it's in the lateral wall, which is a bit more difficult to handle. As you can see, this score gives you the complexity of the case and the need for an alternative procedure or for very good preparation before you try your procedure. Now, as I said, there are two main methods for doing the myomectomy. One is the electrical one, which is practically the resectoscope. The resectoscope that the urologist use prostate pathology, the gynecologist adopted, and now they can do this myomectomy by cutting layers of the myoma. You will have some chips that will get out from and this will be taken off with the resectoscope, which is a bit time consuming, but that depends on the technique, that depends on the size of the myoma, etc. So in type 0 to 2, you can use this type of resectoscope, which can use mono or bipolar energy. Of course, bipolar being less aggressive to the surrounding tissue and less exposed to complication. In type 0 and 1, so fibroids which are inside the cavity totally or in a majority, there is this other option which was developed in the last decade, let's say, which is the hysteroscopic morcellation. You can find it in different names. Some call it shaver, some call it tissue removal device. The idea is the same as the laparoscopic morcellation. The tissue is cut, and the chips, if you like, the fragments are taken off by a vacuum pump. So it's there is as you can see meta-analysis that comparing these two methods practically found no difference in efficacy in fluid distension deficit, and the operation time is shorter because exactly this, because you don't have to take out the chips. Also, the risk of complication and cervical tears and endometrial destruction is lower in the case of a morcellator, and there is a better quality for pathological examination. Now I have a film here. I will. I hope you can see it. I will leave it just to give you an idea how the morcellator works. So here you have a fibroid inside the uterine cavity at type 0, and this morcellator, which is completely mechanical, no other type of energy, is in pathology inside the channel, and then outside in a jaw where you can separate and send to pathology all the better than in a classical resectoscope, because the tissue is not damaged by the electrical current is not cauterized, if you like. So the pathologists are more satisfied issue on one side. And on the other side, the other thing is that you do not destroy the endometrium, which is important in this case and in most of cases. Patients being, if you destroy the endometrium, of course, this will impair future pregnancies and future future the future of the uterine cavity. Sorry about that. I was trying to see if I can move a little bit the film so that we can get to, this is non-edited, so it's like the real time. The procedure took like 6 minutes in all, and you just pass the shaver, you take the tissue out, and to the end, you can see here the whole cavity. During, of course, the shaving, you don't have a very good distension, but the cavity is now empty, and the result is very good. Okay, so I go to the next topic, which is safety and preparation. I won't get into many details, but what I want to say is that for myomectomy, and especially for big myoma, it is important to have the patient immediately after menses with no endometrium or very thin endometrium, and then to have the myoma as small as possible, as accessible as possible. So for this, you can either use, if it's still available in your country, ulipristal acetate, which is a selective progesterone receptor modulator, or you can use GnRH analog. There is a slight difference. The GnRH analog is toughening the fibroid, and it could be a little more difficult to have the slices. If you're doing, you shouldn't forget that there is a safety limit of 5 millimeters from the myoma to the serosa of the uterus. If it's less than that, your energy or your this is not something to want when you're working with energy that could affect all the other organs inside the pelvis. And another thing to be mentioned is the cold loop resection. So you can use the resectoscope, but without the electrical current, and you can use it to push, if you like, the myoma, to dislocate the myoma from the pseudocapsule. And from play with this uterine massage and then get the myoma more accessible for your resection or for your morcellator. This is very important because it doesn't destroy the myometrium. It diminishes the vascular injuries and the risk of the distension media to pass into the vessel. And also the postoperative occurrence of intrauterine adhesion is less if you use, especially the electric bipolar energy destroys the endometrium, and then it can produce intrauterine adhesions. So, as I said in the last part of my talk, I will speak about some thinking outside the box, if you like. What it happens is that, as I said, you have to take the chips out every myomectomy has this disadvantage, inconvenient. But there is this multicentric study done in 2021, fibroid inside the cavity. Of course, they didn't use the electrical current. They only used cold instruments like scissors or like the cold loop I described before. But then they left the myoma inside the uterine cavity and followed the patient for 90 days with the ultrasound. And the interesting finding was that in 200 cases, from the 200 cases, 94% had no fragments intracavitary at 90 days. Now, this is, as far as I know, the only study. It is a little bit different from the approach that we usually have to take and to restore the complete anatomy and the complete. But it could be an interesting development for the cases where you want to perform this myomectomy in ambulatory settings. You don't want to have an operation that lasts too long and to create all the complications related to that. So this is my talk. I thank you, and I hope that this topic and all the other related to minimally invasive surgery, that the hysteroscopy could become our next stethoscope for the gynecologist. Thank you.
I'm Dr. Sunanda. I'm professor in OBG department, Srinivas Medical College, Mangalore. And today I'll be presenting a most important topic for women, that is awareness of menstrual cup among reproductive age women. So this topic was chosen because in Indian scenario, we do have a lot of taboos and cultural differences in menstrual cycle, and also the usage of menstrual cups as well as other modalities. So with the thought that how our woman sees the menstrual cup. So this is the first type of menstrual cup which was introduced in 1932. Till now, many countries, they are not using the menstrual cup, even though it is well used in the developing countries. And probably the future women may use the menstrual cups as they are quite user-friendly, and also there is a reduction in the chance of infection, which is more concerning for women during the menstruation. And the capability to reuse the cups for 10 years is the advantage of the menstrual cup. Most of the women are not aware that this can be reused, and also the cost in women's life is less compared to the pads or the tampons. So we have conducted a 1-month questionnaire among the medical students and the healthcare professional in our institution. And we have done a knowledge scoring system scale from 1 to 10 to establish the factors about awareness on the menstrual cup, attitude and practices on the use of menstrual cup in the reproductive age women. And the inclusion criteria we have taken was reproductive age women between 15 to 45 years who are working in our institution. And exclusion criteria, we have taken postmenopausal women who has undergone surgical menopause, or a girl who has not attained menarche. And all data was statistically analyzed, and this is a descriptive statistical study which has been statistically done by chi-square test in a suitable statistical analysis, and the appropriate data was used. And also we have used SPSS version 22, and the significant statistical value, we have taken p-value as less than 0.05. So as we are all aware that menstrual cup is a bell-shaped device which has high-grade medical silicone, rubber, latex, and elastometer, which can be used during menstruation into the vagina, and it is about 6 centimeters long, 4.2 centimeter in diameter, and it is can be re-inserted once per month, and it can be used for 5 to 10 years. And the cup collects most of the blood, and there is no need to reuse the napkins, and this is very user friendly. Coming to the results, we had 508 participants which are included in the investigation, that is by questionnaire, and maximum number of participants was in the age group of 21 years to 25 years, and most of them are undergraduate level education, and 15% were graduated, and most of the participants are unmarried, about 89%, and they are also a low
Slušajte,
socioeconomic.
ja sad ne mogu tu ni sliku.
Yeah.
Možete profil picture staviti. Ma nemam ja profilnu sliku, nego ja hoću da me on vidi ovak sa
Hello?
kamere. To neke ne štima.
So this is the table which shows the awareness and demographic data. Most of the girls are in the 21 to 25 years, and the graduation undergraduates are most common. That is the 355 patients among 500, and the medical students were 269. And we do had students with occupation as a medical student. And the current sanitary use, most of them are using napkins, that is sanitary napkins in Indian scenario. And in our institution, only 1.5%, that is 8 students were using only the menstrual cups. And it is observed that most of the girls were using both combination of cups as well as other methods like napkins or the sanitary towels. So because they were worried about the leakage, and also they are worried about whether the menstrual cup will fall down and they will have problem with the menstruation. So they were using the both methods along with the cup. And this is the table showing the population study, the demographic data, which includes how the patient was aware of the menstruation results. And this is the table which is showing about the complications of the menstrual cup in our patient. Most of them had abdominal pain, itching because of the use of the menstrual cup. Many participants observed that there is a taboo regarding usage in the unmarried girls because they're worried about the sexual intercourse and also about the future fertility plans and whether it will affect their fertility. And many feel that it is very cumbersome to use, as a cup looks quite difficult for them to insert into the vagina. And this is the table which shows about the knowledge score among our population. That is, we scored around 1 to 12 scale. And in this, good knowledge for women as well as the student had, and poor knowledge was noticed in 21% of the patients. And this is regarding the age group and the knowledge of regarding the menstrual cup. And why it's not so popular in the Asian population, because most of them feel that after using the menstrual cup, there may be a leakage, loss of fertility, or loss of virginity. And the support from the family as well as PE teachers also may decrease their usage, and also they feel a little scared to use the cups. And they're quite worried about the side effects as well. That's why it's not so popular in the Southeast Asian countries. In this study, we want to explore the awareness and knowledge and feasibility and tolerability using the menstrual cups compared to the sanitary products like tampons or the pad. The outcome showed that it is realistic, environmental friendly, and economic, and advantage of being that it can be used reusable. So this was not made for the patient's awareness. So they were not aware that we can reuse it again. they thought that once it is used and it is disposable. So regarding the usage and the knowledge, it is quite important for us to teach in the schools as well as for the college students about the use of menstrual cup, as it can decrease the sexually shared infections and also the infections like HIV, which is very common in Southeast Asians as well as in the African countries. There are various studies which are conducted in India as well. Like in Gujarat, they have studied a group of people, students like 20 to 60. In that they made that it is quite friendly, user friendly, and also the side effects are also less, and cost wise it is less cost compared to the pads. And one of the other modalities what they have observed is that it's very difficult to dispose the pads, as they are plastic and they are not environment friendly, and compared to menstrual cups which can be reused, so there is no problem with the disposable as well. And to maintain the sanitary hygiene during menstrual cycles, it's very easy in case of menstrual cup. Nearly 72 participants had a good awareness regarding the menstrual cup, and about 58 had the knowledge, but they were scared to use the menstrual cup. To conclude my study, this investigation provides a conceptual and precise evidence about the awareness of menstrual cup among the reproductive age women in our state, that is Karnataka state in Mangalore. And awareness, knowledge, attitude, and acceptance of the use of menstrual cup are good among the educated groups compared to the women or the girls who had low socioeconomic status and less education. And hence it is established that higher educational status and occupational levels are more aware about the procedure and the usage, as well as about the cup advantages. There is a vast diversity between the awareness and actual use and willingness to use about regarding the menstrual cup. As there is multiple advantages regarding the menstrual cup, the usage of menstrual cup among Indian women, particularly in the rural area where the basic hygiene products are deprived, is most important to prevent the complications of the pads or the sanitary napkins. Hence, awareness and increasing the programs such as meetings and counseling sessions highlighting the importance of menstrual cup among the reproductive age women is most important, and it should be conducted by the government setup, including the central state health administrative authorities. The future research is that we need to investigate this issue for the perception of the variety of stakeholders, including the healthcare providers, teachers, relatives, parents, as well as men. Other stakeholders may shed the light on the further obstacles regarding the use of menstrual cup. They might facilitate the use of menstrual cup use and help identify the methods in which the menstrual cup improves the intersectional inequalities, gender impartialities, as well as equity within the communities and schools and children's. And also, as we are aware, these are environmental friendly, and disposable is also quite easy. So this is my conclusion of my talk and the paper, and these are the references. Thank you so much for giving me this opportunity to present my paper.
Risk for uterine cancer by artificial intelligence and machine learning using routine blood panels, just routine blood markers. So thank you for the opportunity to present this to the esteemed audience at the International Conference on OBGYN. Just to give a brief introduction of myself, I am an internal medicine physician. Actually, I'm not from UK, it's actually US. BSRM Consulting is in US. And I have worked extensively for large university medical centers and multi-hospital delivery networks. And for the last 20, 25 years, I'm also involved in artificial intelligence and machine learning to build applications for clinicians, practicing clinicians who are taking care of the patients. So that is my passion. And as you know, in the last 5 years, there has been a lot of chatter. There is a lot of focus on using AI in healthcare, and that is kind of exponentially exploding. So I would like to share this presentation, mainly focused on uterine cancer, but I have done quite a bit of work on other cancers, chronic diseases as well. Okay. As you know, just focusing on the uterine cancer, it has increased tremendously, and it is in 26 of the 43 countries around the world. And another thing about this is that it is more higher in the Black and Asian women, and almost like half in white women. And one of the important aspects of this is that the early you detect the cancer, the survival is extensive. So as you can see in the bottom middle picture, if you diagnose uterine cancer in the stage 1, the 5-year survival is about 87%. And it actually goes down with the stage 2 and stage 3. And in stage 3 and stage 4, it drops down from 57 to almost 18% survival. So it is extremely important that we need to detect this cancer early so that there is a very high survival rate. So that is the focus of my presentation. How can we detect uterine cancer very, very early? So that is the whole idea of this presentation. So here, there's a book called Your Blood Never Lies by James Laval. The whole idea of this book is that blood that actually perfuses through our body about 100,000 times a day from head to foot, perfusing all the organs and collecting all the waste products. It has got tons and tons of information, and then we are using that. We are actually only scratch the surface to get the information from the blood. And one of the things that we do is blood test, like lipid panel, electrolytes, CBC, and things like that. These are the tests that we routinely do once in a year, whenever we have a minor surgery. So that data is available. And the blood results are extremely objective. It is not subjective. So if you go to any patient going to a doctor, if they go to 5 different doctors, you get 5 different opinions. Whereas if you send your blood to 5 different labs, the chances are that the results will come back. If it is like a reputed CAP accredited labs, you most probably get the results back, which is kind of within like 5% of the error rates. It's all be consistent. So one of the important things is blood never lies. So it is actually the window to human health and disease. So that is the core idea of my presentations, is that we are only relying on the blood to be able to identify the risk. So that is the focus of my presentations, and using AI and machine learning and the blood results, can we identify risk? And especially today, I'm going to focus on just the uterine cancer. The practicing physicians in the group really know how we practice medicine. And we have been practicing medicine for the last 50 years, exactly the same way. When the patient walks into your room, we have a conversation with the patients about personal history, family history, then do a complete physical examination. And then we formulate within our head, what could be wrong with the patients. We come up with about 5 different diagnosis possibilities, and based on that, we order test. Blood test. Initially, we typically order blood test and maybe some imaging. And then we say that, okay, let me get the blood test results, and then we'll continue to proceed. So this hasn't changed, and this is a very, very manual process. It is, cognitive in nature. So once the blood is sent, all the rest of the process until we get the results back, it is very much automated in the last 50 years. And especially today, there are extremely high accuracy instruments, robotics, information technology, so that the blood is, barcoded, making sure that it is tested for any kind of lysis, make sure that quality control is done, and then it is analyzed, and the results are back like within like 15, 20 minutes without even any human touching it. So it's extremely accurate, and it's extremely, state of the art. But once the results come back, again, the manual process starts. The physician's actually going through one test at a time, and they are actually looking at, whether the test has highlights, like, so high or low. If there is no like highlights, we just go on and say that, okay, everything is normal, come back. But that you have to kind of think through that. Is that the good way of practicing medicine. I'll tell you why. So one of the important things is 70% of today's medical decisions depend upon lab tests. CDS has already said that. So a lab test plays a 70% important part in the diagnosis. And as you know, today, a number of tests has exploded. There are 14 billion tests are ordered every year. There are about 4,000 to 5,000 different types of blood tests that are available today. So as you can see, it's extremely complex process to be able to identify the problem using blood test panels, which are at least about 30 individual tests. So human brain, or physician's brain, are not built to be able to analyze all these 30 tests together. We actually look at one test at a time, which may not be really helpful. So as a result of this, 29% of the diagnoses are wrong diagnosis, which may result in like unnecessary test, extend the patient's stay, and even produce harm or even death. So it's extremely important that the basic, interpretation of the test results are extremely important to put the patient on the right path, to be able to identify what the problem the patient may be having so that we can work up the patient. So that is extremely important. So when I talked about reference intervals, that is what we use. Originally, it was called normal intervals. Now it's reference intervals. A lot of people don't know that. The way we constructed the reference intervals is that about 50 years ago, we collected blood from 100 self-declared healthy volunteers. They declared themselves as healthy, and then they filled up a little form, and then they gave the blood, and we analyzed the blood, and then we actually plotted a Gaussian distribution curve and said that, okay, 95% that is within 2 standard deviations is considered as normal intervals. And even today we use that based on 50 self-declared volunteers. And who are them? They are actually lab techs, because those are the people who can, easily we can have access to them because they are working in the lab. It's very difficult to get their blood. And most of them are in the mid-age group, like, maybe 30s to kind of 55, 60, and none of them are over 60. So this reference intervals doesn't represent people over 60. As you know, majority of the patients are old age, so the reference intervals doesn't even apply to old people. So that is a problem with the reference interval. So if you have a panel of tests with a whole bunch of tests, which is either high normal or low normal, according to the reference intervals, and the physicians are going to say, okay, fine, but is that really true? So that is what is, AI can help to identify, how to analyze this, multi-dimensional, which is 40 different dimensions, right? So we can look at 3 tests and kind of compare each other, but we cannot look at 40 different tests and compare the relative importance of each of those test results. That is where the artificial intelligence can come and help, because artificial intelligence is extremely, we call it as a machine learning, which is a subset of artificial intelligence. It is extremely very powerful to be able to, multi-dimensional data, and especially lab test results, which are actually very numeric and very objective. Okay, so as I said, again, this, it is not very useful for people over 60 years old. And then, it has got only 95%, the 2 standard deviations, because it actually omits 5%, like 2.5% on either end. So if it is, even though it's kind of normal, we consider that kind of abnormal. So it's extremely important how to interpret the test results, because if you are going to rule in a diagnosis, we want to be diagnostic, then we want to make sure that the lab test is close to within 1 standard deviation. So basically, if it is 1 standard deviation, then it has to be actually outside this curve to label a patient having some kind of a disease. If you want to rule out saying that the patient doesn't have a disease, then you have to be extremely careful that it has to be within 1 standard deviation, which is the best normal range, if you want to call it that way. So that is extremely important. A lot of physicians actually don't do that. They just look at the highlights and move on. So that is a problem. Okay, so this is a diagram of a model, a machine learning model, where I have just illustrated it, how exactly it works. So we are actually feeding. So what I did was collected a whole bunch of thousands of real patient data, which is completely de-identified from the hospitals in Boston. And then we have data going up to 50 years. So in this particular case, uterine cancer, we collected patients with established uterine cancer diagnosis and looked at their blood profile up to 3 years before they were diagnosed. So before they were diagnosed, we looked at that. So we collected all the data, and also we collected equal number of patients who didn't have uterine cancer. So they are considered as controls, and about 10,000 patients. And then we actually trained a machine learning model to identify the blood profile up to 3 years before, whether it can identify the risk for uterine cancer based on the real data of past patients. So, and the input to the data is just the gender, age, and routine blood markers like CBC, WBC count, red blood cell count, lymphocyte, neutrophils, things like that, and electrolyte, sodium, potassium, calcium, albumin, things like that, as well as lipid panel, cholesterol, triglycerides, HDL, LDL, things like that. And then the output of the model is whether the patient has uterine cancer or not, and what is the confidence of the model saying that the patient has, not has risk for uterine cancer or not. So that is the whole idea of the model. So this model can be kind of tuned either for diagnostic and for screening. But the whole idea about this is that we need to use this for screening. So because there are other specific tests that we can do if the patient has a high risk. So the best thing is that on a population level, we want to screen. And when we label a patient as not having a risk for uterine cancer, we have to be 99 to 100% sure. But if we label the patient as uterine cancer patients, then we don't need that much of accuracy because there are other tests that we can do to be able to confirm that. So as a screening, we need to make sure that we have a very, very high, what we call negative predictive value. So if you say that patient doesn't have uterine cancer, we have to be almost 100% sure. So that is how you kind of tune this model to use that as a population health screening method. Okay, so in our case, what I did was 10,000 patients, 5,000 patients with no uterine cancer, 5,000 patients with established uterine cancer, go back and look at their blood profile up to about 3 years before. And it turned out to be that it was able to perform with an accuracy of like 93 to 94%. And it also, the modern artificial intelligence will also give you the reasoning for that, which is extremely important for us as physicians. If a model actually gives them a prediction that the patient has a high risk for uterine cancer, the next question as a clinicians we'll ask is that why is that risk high? What are all the markers that shows the risk being high? Is there any evidence? So that's what we want. So it's important that nowadays the AI, the new modern AI in the last 2 years, is able to give evidence as well. Previously, the AI was called, like especially machine learning was called as a black box model because we don't know what is inside the box. But now they have turned that into a glass box, which you can actually see what is happening and can interpret how the results are being generated. So in this particular case, on an average, these are all the markers that points to the uterine cancer. As you can see, triglyceride, cholesterol, albumin, protein, bilirubin, and so on and so forth has a high value in identifying patients with risk for uterine cancer up to 3 years before. And then, as you can see here, it has got a sensitivity of like 92.9, which is all 93%, which means that it can identify, uterine cancer up to about 93% accuracy, which is actually diagnostic. And it can, with the 94% or 95% accuracy, it can identify the patient without uterine cancer. So you can look at here, it has got a negative predictive value of about 93 and a positive predictive value of 94. So in this particular model, it actually did a pretty good job of either as a diagnostic, either labeling a patient has uterine cancer or not, with almost like 93 to 94% accuracy. Okay, so this is 2 example patients from the group, which so basically when you train the model, we take 70% of the data to train the model, and we keep 30% of the data separate to test it. Those patients are not shown to the model. They're absolutely brand new patients that the model has not seen, and then we'll test it whether how well the model performs. So one example in this particular case is one patient who was actually labeled as 100% risk for uterine cancer, and it also gives you what are all the markers that are being considered that supports this risk. In this particular case, as you can see, the age of the patient, the triglyceride, albumin, cholesterol, and protein, pointing towards a high-risk patients, because this patient's profile matched with a majority of the patients who actually developed uterine cancer in the future. So that is why it's saying that the blood combination of the blood results actually pointing to it. You may want to look at it. This patient is actually a candidate for CA-125 because CA-125 is still not a very accurate test, but it's much, it's a cancer marker. So that is commonly used for uterine cancer. So this patient is a very good candidate for that. If the CA-125 also shows high values, then that patient may be a good candidate for maybe doing a pathology test like a DNC. So the second patient on the right side, the model predicted as a 92% confidence of no uterine cancer. And it also gives a kind of the same kind of markers like triglyceride, red cells, creatinine, sodium, in this case, creatinine, sodium, and chloride, showing that this patient's profile doesn't look like this patient has a risk for uterine cancer. Okay, now I looked at the average marker value across patients with uterine cancer and without uterine cancer, and I took like 8 markers just to illustrate it. As you can see here, the red one is a patient with uterine cancer, and the blue is without uterine cancer. This is actually an average of blood test results over a period of 3 years. So as you can see, consistently there is a difference between like cholesterol. Uterine cancer patients has a slightly high cholesterol, not a whole lot, but at least slightly high cholesterol. They have a low bilirubin. Their age group is usually they are kind of older patients. And then if you look at the liver enzymes, ALP, ALT, and AST, all of them are actually at a lower end, really at a lower end. Like in this case, ALT is really less than half. Same is the case with AST for uterine cancer patients compared to controls. And also lymphocytes is a very low compared to the controls. And here, the CA-125 is actually not used to build those models or to predict those models, because CA-125 is not usually done as a part of the routine blood test. But this patient, I had CA-125, so I kind of also looked at if there is any difference. And you can actually see majority of these patients with uterine cancer has a high CA-125 compared to control. Okay, so I also said that the AI now is called explainable AI. It can actually give explanation for it. And so you may ask, what has the triglyceride to do with uterine cancer? So there are 4, peer-reviewed journal articles that actually shows the link in this. The first one, a study from the HUNT-2 study reported that a positive association between triglyceride levels and endometrial cancer risk, with the highest quartile of triglycerides showing a significant association with endometrial cancer risk. A second paper highlighted that hypertriglyceridemia was statistically more frequent in patients who had undergone bilateral salpingo-oophorectomy, both before and after menopause, than in the corresponding non-endometrial cancer controls. The fourth one, additionally, it has suggested that higher estrogen levels produced in adipose tissue mechanisms more specifically related to triglyceride may also be involved in the endometrial cancer. So typically obese individuals with a high triglyceride, high fatty tissues, high estrogen levels, they are more likely to develop uterine cancer. Then the fourth one, obesity often associated with high triglyceride levels may play a significant role in this association. Further prospective studies are needed. So these all point to a link between triglyceride and uterine cancer. So what about cholesterol? Because our model also suggested that cholesterol may be a marker which may show a high risk. A systemic review on dose response meta-analysis of observational studies found that an increase in cholesterol consumption by 100 milligram a day was associated with 6% increase in endometrial cancer risk. Additionally, Mendelian randomization analysis have suggested that a role for cholesterol in the development of endometrial cancer. So you actually see triglyceride and cholesterol, especially lipid panel, is extremely important for identifying whether the patient has a risk for uterine cancer. Then what is the role of albumin? It's generally a protein, right? A study of gynecological cancers, including uterine cancer, highlighted that low serum albumin levels are correlated with malnutrition and weight loss, which are factors that can impact cancer prognosis. Another study found that low preoperative serum albumin levels are independently associated with poor overall survival in endometrial cancer patients, and this finding suggests that albumin levels may have implications for prognosis of uterine cancer. Another study, a large prospective cohort study, indicated that an inverse association between pre-diagnostic serum albumin levels and an overall cancer risk, including lung, colorectal, and liver cancer. In this particular case, uterine cancer is not linked, but lung, colorectal cancer, and liver cancer are linked. And if you can generally know, most of the cancers follow the same path. So most likely, this is something that we need to be investigated about the association of albumin and uterine cancer. And what about the proteins? Proteins, albumin is also a type of proteins. As you can see, majority of the specific markers like CA125 are actually protein markers. So here you can see a study investigated a proteinomic spectrum of albumin-associated peptides in serum samples from endometrial cancer patients and controls. The study identified there are 3 mass peaks as potential distinguishing markers for endometrial cancer with a sensitivity of 65.2% for detecting endometrial cancer, even in stage 1 early cases. However, these peptides are also detected in patients with myoma uteri, indicating a lack of specificity to endometrial cancer. So it's not very specific, but you can actually see in 62% of the patients, it actually increased. Protein biomarkers that I've already told you, CA125, and another one called HE4, which is human epididymis protein, has been found to be elevated in endometrial tissues and serum endometrial cancer patients, making them a potential target for cancer detection. So basically, even the regular total proteins is actually a marker, because even CA125 and HE4 are also proteins. So there is some kind of a signature in even the total proteins that the AI model is able to pick up. A report from the population-based case control study in Shanghai, China, suggested that dietary protein has been implicated in the etiology of endometrial cancer, with the evidence of epidemiological studies showing a limited and controversial association between protein intake and endometrial cancer risk. Finally, what exactly AI is doing? This is my favorite slide. The medical science, even though we think that it is very much advanced, if you consider medical science to be a 1 million page book, we have only read the first 100 pages. We still have 99,900 pages, which we don't even know we haven't even read. But what AI is able to do is that it is able to look at all these markers in this particular case and show correlations between markers and the risk for cancer. So there may not be any articles published, there may not be any research done yet, because we are still yet to read the 99,900, but this may point to potential opportunity for clinical research to show what is the biochemical mechanism of those correlations, which is extremely important. In our case, we actually seen there is a link between albumin, triglyceride, and proteins in uterine cancer. And we also saw that triglyceride can lead to fatty tissues and lead to estrogen release, which is which can actually lead to uterine cancer. And also, glucose, which I haven't shown. Glucose is actually, especially diabetes, is a risk for any type of cancer, which can lead to high insulin levels and reach to inflammation, and that can also reach to cancer. So the whole idea here is that the AI will be a phenomenal tool for us to be able to identify risk, not only for uterine cancer, various cancer, because I've done work with lung, colon, liver, cervix, ovarian cancer, for example, just a silent killer. It'll be great to identify the risk for ovarian cancer early, and even other chronic diseases like multiple sclerosis, autoimmune diseases, and chronic kidney disease and things like that. So I've done a whole bunch of work on this, and there is a phenomenal potential for this. So let me stop here, and I'd like to take any questions, comments, or suggestions. You can reach me at raj.gopalan@bsrmconsulting.com if you have any questions and would explore any kind of collaborations. I'll be more than happy. Thank you.
Thank you, Dr. Gopalan. It was an excellent presentation, and hope
where we were calculating the decision to delivery interval in emergency sections in the department and seeing how much they are able to match to the limits set by the NICE guidelines, and things that we could improve to decrease the delay and in turn improve patient care in general. So I would like to thank my consultant who was supervising me in this audit and the other participants of the audit. So Basically, the classification of cesarean sections could be into 4. Category 1, where there is immediate threat to the life of the woman or the fetus. Here we aim to deliver the baby in 30 minutes. Category 2, where there is a compromise to mother or the baby, but it's not immediately life-threatening, where we have a decision to delivery interval of 75 minutes. Category 3 is where there is no maternal or fetal compromise, but we need to deliver the baby. And category 4, which is an elective cesarean section, which can be timed to suit the women and the hospital staff. In this audit, we are going to look into category 1 and category 2 cesarean sections. So the aims of the audit were to identify where the decision to delivery interval for category 1 and 2 cesarean sections were meeting the standards that were determined by the NICE guidelines, to find out the causes for delay and the steps that we could take to decrease the number of delays, find out to identify any improvements as compared to the previous audits, and identify any key determinants which are causing the rise in the number of cesarean sections and try to decrease them, which is as per using the Robson's criteria, which we would see in some time, and check if there was any harm caused by the delay to deliver the baby to the mother and the baby, in the form of requirement of neonatal admission or hypoxia to the baby, which was seen in the babies that had a delay in delivery time. And again, the steps that we could do to decrease this and improve patient care. So as I told earlier, the standards that were determined by the NICE guideline is 30 minutes for category 1 cesarean section and 75 minutes for category 2 cesarean sections. So we were following a trend in our department, and in the last 2 years, there has been a good improvement from 41% to 17% in the last studied audit that was October to March 2023 in both category 1 and category 2 cesarean sections. This is because of effective communication between the team members and letting the staff know and implementing measures to decrease the delay between decision and delivery time. So this was a retrospective audit. So the first 6 months were between October 2022 to March 2023. We came up with some measures to try and decrease the delay, and then we studied the outcome between the previous audit and the present audit. All category 1 and category 2 cesarean sections were included in the study, which happened in Royal Albert Edward Infirmary, which is a district general hospital and NHS teaching hospital in UK. The data collection tools were the documentation from the cesarean documentation, including the doctor's documentation and the midwife's documentation, and also going through the patient notes. So this is the general number of emergency cesarean sections that happened between October 22 to March 23 and were compared to April 22 to September 22, which was the previous 6 months. It was seen that there was a rise in the number of cesarean sections from 440 to 528. It was seen that there was a slight almost similar number of category 1 cesarean sections, but quite a big increase in the number of category 2 cesarean sections during this time period. So it was seen that in 17% of the women who went for a category 1 cesarean section, there was a delay of more than 30 minutes. The range of the delay was between 1 to 33 minutes, beyond the 30-minute time limit. It was seen that in 12 out of 16, the reason was not documented. The reasons that were documented were requirement of general anesthetic due to ineffective spinal or epidural top-up. One of them was seen a requirement of another patient that needed attendance before the present patient, and one was seen where the patient was not consenting for a cesarean section. So these were the reasons that were seen. And as you will see in the future slides, we did set up a conclusion and action plan to target these things. And in category 2 cesarean sections, it was seen that there was incorrect documentation or no documentation of delay in 5 cases out of the 195 total category 2 cesarean sections. It was seen that 42 that out of 195, that is 21% cases, had a delay in the decision to delivery time, which was beyond the 75 minutes. And the range of delay was 2 to 442 minutes. It was seen that 9 out of 42 had no reason that was documented on the notes. And then the other reasons included clinical activity or theater in use, requirement of opening the second theater, awaiting the consultant, awaiting the partner of the patient, awaiting pediatric team, awaiting blood and blood products, and waiting for fasting for the patient and handover. That is the shift change time. Now, as per the complications that were seen, the most common complication that was seen was hemorrhage, which was seen in 6 cases in category 1 and 12 in category 2 cesarean section. It was seen that all the complications were adequately documented and adequately managed by involvement of senior support, by involvement of urologist and specialist surgeons in certain cases, and involvement of pediatrician and medical care team in cases of maternal seizures. Now, Robson's classification, this is a classification that was introduced by WHO that divides the cesarean section as per the characteristics of the women. As you can see, group 1 is a nulliparous woman in spontaneous labor, term nulliparous woman. Group 2 is a nulliparous woman who had a labor induced or who had a section before she went into labor. Group 3 is a multiparous woman, term multiparous woman in spontaneous labor. Group 4 is a multiparous woman with induced labor or who had a section before laboring. Group 5 includes all the women with previous cesarean section scar who are term. Group 6 includes nulliparous breech. Group 7 includes multiparous breech. Group 8 includes a woman with a multiple pregnancy. Group 9 includes any patients with oblique lie or transverse lie, and group 10 includes the preterm cesarean sections. So we will see, we classified our cesarean section based on Robson's classification to try and decrease the number of cesarean sections that are happening. So as you see, as compared to the previous audit, the current audit had a similar trend where we can see the induced patient, that is group 2 and group 4, had more cesarean sections as compared to the spontaneous group 1 and group 2. Previous cesarean sections were around the similar range, which was a small % of the total sections, which shows effective management of previous cesarean section women who are aiming for a vaginal delivery. The breech presentations were a very small number, which shows effective diagnosis and correct management of breech presentations. And there were no twin gestations or multiple pregnancy gestations that required a category 1 cesarean section. That again shows a good management of multiple pregnancies. And there were similar trend in the preterm cesarean sections. As we'll see in Robson's category 2, again, similar trends were seen. The highest number of patients that had a cesarean section were nulliparous women who were induced labor. So as per the Robson's classification, it was seen that both in category 1 and category 2, the highest number of sections belong to the group where the labor was induced, which is 13.8%, which in spontaneous versus 59% in the women that were induced. Previous cesarean section, 6.9% had a category 1 cesarean section and 2% had category 2, which shows a good management of vaginal birth after cesarean section. 7.9% women with breech presentation needed an emergency cesarean section, again shows good management. However, there is some improvement that we could still do in effective diagnosis and treatment of breech presentations, like timely scans, offering of external cephalic versions can be done. However, there are cases where a woman might present for the first time with breech presentation in labor, and then that accounts for the emergency cesarean section pool with breech presentation. In our audit, only one woman with multiple pregnancy required an emergency cesarean section, which was a very good management for multiple pregnancy cases, which has contributed to the multiple pregnancy clinic that we are running now, especially managing the pregnant women with multiple pregnancy. 1.3% women had a cesarean for transverse lie or an oblique lie, and 7.9% women had preterm cesarean section. Now, in comparison with the previous audit, we can see that there is, if we compare the total number of decision to delivery delay, it was seen around 20% of cases as opposed to 16%, with slight increase in the delays in both category 1 and category 2 cesarean sections. However, this can also be attributed to the fact that there was a high number of total emergency cesarean section in the last 6 months, that can involve the delay due to needing of opening another theater or awaiting theater staff and things like that. However, it was seen that there was a very good improvement in the documentation of the decision to delivery delay, which was where there was seen that incomplete documentation was seen in 36% as opposed to 50% in the previous audit. This could be accounted due to increased awareness amongst the midwives and the doctors to correctly determine the delay and to document the delay in every cesarean sections, which was done with emails sent to everyone and included in the induction for the new doctors that were joining the trust. We can see the harm caused due to delay, that is the babies requiring neonatal admission. It was seen that most of the babies that required admission was because of hypoglycemia, sepsis, jaundice, and only one patient had gases that were low, and the others had fairly stable gases. So to conclude, I would like to say that decision to delivery interval standard was met in around 80% of the patients. There was a slight decline in performance than previous 6 months. However, improvement in the documentation of the delays was seen. As seen according to the Robson's criteria, it was seen that the induced group had the maximum number of cesarean section, but there was a decline as compared to the last audit where it was 63%. It was seen only in around 46% in the second audit or the re-audit. Most of the maternal complications were adequately documented and adequately managed with senior support and other support as needed. With regards to the babies, only one baby had low gases, and there was no admission to the neonatal unit for fetal hypoxia or cooling, as it was seen. So there was no hypoxic injury in the babies that were admitted to the neonatal unit. It was more for jaundice, sepsis, hypoglycemia. The limitations of this audit is the decision and the delivery time it might be documented by checking the different clocks or the different time screens, there can be a difference of 1 to up to 5 minutes in different clocks. So that needs to be accounted for. And Robson's criteria has only been calculated for the emergency section, which was a part of our audit, but it should be applied to all the cesarean sections that are being done. As end of our audit, we made the following recommendations. We have to encourage the staff. We have to congratulate the staff in improving the documentation, but we have to still emphasize the fact for the need for careful documentation of time and calculation of delay in all cases. Try to minimize the delay as much as we can, to involve the senior staff early if needed, to involve the anesthetist in making the decision of the adequate anesthesia that is required for the cesarean sections. Appropriate classification of the cesarean sections. Again, we have to ensure that if it's a category 2 cesarean section, or would it be classified as a category 3 cesarean sections, so that the delays like need of steroids or need of consultant support, those things can be reduced if they are adequately classified. We have to have an appropriate documentation of the reason for delay, if there is any. It was suggested that we could include a compulsory column in the documentation where you cannot go to the next page without documenting the delay, and automatic calculation of the delay by the computer system. We are trying to incorporate the Robson's classification of cesarean into the documentation that we do for our notes of the cesarean section. That will help in looking into the areas where we could still improve. And again, a re-audit in 6 months. So these were the recommendations that were made, and the action plan based on this was to try and include a compulsory column that calculates the decision to delay on the software, to again emphasize the importance of documentation to the hospital staff, including doctors and midwives, and to involve anesthetist in the next audit to look into the steps that we could do to decrease the anesthesia-related delays, and we decided to re-audit with these changes in the next 6 months. The references are as follows. This quality improvement activity helps us in improving the patient care in our trust, decreasing the delay and reducing the harm caused by the delay to the mothers and the babies, and ultimately aim for a healthy mother and a healthy child. Thank you so much for kind attention.
Thank you a lot for your presentation. It was very good. I think we learned a lot about